brain hemorrhage. And although dAVF and AVM are both high flow vascular malformation, the dAVF still differs from AVM, as AVM can be found in within the brain tissue, while dAVF are found in the surrounding of brain and spinal cord. For location, as it is a dural fistula, so theoretically it can occur in any part of the dural matter, but the most common places are transverse, sigmoid, and cavernous sinuses, and the second common ones are straight sinus, tentorial incisura, superior sagittal sinus, tubular, anterior cranial fossa, and foramen magnum. How does a dAVF develop? Where they come from is still controversial, but the most part are acquired lesions, usually in middle age and older adults. And the most inciting features is previous sinus thrombosis, typically for the transverse sinus, and we such as mastoiditis, sinusitis, pregnancy, combined oral contraceptives, tumor invasion of intracranial venous drainage, for example, like meningioma. Even though dural fistula are found in outside the brain tissue, but it is still have some neurological symptoms from an asymptomatic state to benign symptoms and aggressive symptoms. In benign symptoms, we can see the patients presenting with parasitic typically for transverse and sigmoid dAVF, and eye symptoms for cavernous dAVF. It depends on the location of fistula. Like if there is a fistula behind the ear, like transverse and sigmoid patient can present with parasitic, as there is a high blood flow with a very fast flow going through the sinus. And for aggressive lesions, patients can present with intracranial hemorrhage, seizures, automatic status, hydrocephalus, dementia syndrome, cranial nerve palsy, and loss of motor function. Sometimes we have to be concerned about the progress from low to high risk lesion, but it is really unusual for patients with benign profile to turn to aggressive symptoms lesions. And for diagnosis, the protocol should be the patient is taken in CT or MRI without and then with contrast, and then if there is a suspicious for dural fistula, they will be taken angiography, CTA and MRA first, and then DSA. DSA is considered the gold standard in both diagnosis and accurate classification in terms of dural fistula. For CT, non-contrast CT is limited for intracranial hemorrhage, venous sinus thrombosis, or edema due to venous congestion, and linear bony defects formed by enlarged emissary veins, similar to the grooving abnormality seen on the plain film, can also be found. For MRI, T2 weighted is more sensitive to the white matter changes of venous congestion or infection when compared to CT, and findings varies from clinical presentation, and including dilated cortical vessels appearing as flow voids located within the corticals without a true parenchymal, venous pouches, prominent occipital arteries, vascular enhancement, osseous abnormalities due to the aesthetics or hypertrophy vessel, sinus stenosis or thrombosis, and the size of venous hypertension. And with any suspicious flow void cluster around the durovenous sinus should prompt additional evaluation with dynamic CTA, MRA, or DSA. CTA is particularly useful in treatment planning by helping define the AV shunt relative to the surrounding brain or scalp. Some studies have shown that MRA has more sensitivity than CTA for the detection of dAVF, 50% versus nearly 15%. For DSA, due to the often extensive supply, a 6-vessel selective angiogram is required in this case, including bilateral internal carotid arteries, external carotid artery, and vertebral artery injections. Next, a super selective angiography should be applied to assess the arterial supply and venous anatomy. Angiographic features associated with aggressive behaviors are leptomeningeal, retrograde, venous drainage, variceal or aneurysmal venous structures, and galenic venous drainage. This is an example case of a 44-year-old male, female presented with focal neurological signs, and this is the initial CT scan. We can see it is a brain hemorrhage in the left parietal lobe, and the patient next is taken to MRI and DSA to confirm a dural fistula. And we can see in the MRI imaging, there is a parenchymal with a blue arrow, and the subdural hematoma with the white arrow. In DSA imaging, it confirms a dAVF with cortical venous reflux and venous ectasia, which is likely the rupture. And this is an example of initial CT scan of 53-year-old man, also later confirmed by dural fistula. For classification, the two most common classification systems for dural fistula are Borden classification, which is user-friendly classification system, and the more detailed Cognac classification system. When Borden classification is categorized based on the venous drainage, and then Cognac as to the direct flow in the involved dural sinus, and or the absence or presence of the venous ectasia. Speaking of Borden classification system, there are 3 types of Borden system, from benign to aggressive. In the Borden 1, there is a drainage of meningeal arteries directly into dural sinus or meningeal vein with anterior grade flow. For there's only 2% of patients in this group have aggressive lesions. And for Borden type 2, an arterial grade here, drainage into the dural venous sinus, and a retrograde flow into cortical subarachnoid veins. And nearly 40% of patients in this group have the symptoms of aggressive lesion. Lastly, the Borden type 3, there's a direct retrograde flow from meningeal arteries into cortical veins or an isolated sinus segment. And almost 80% of patients in this group have aggressive lesions. This is the description of cognac classification and equivalent type of borders. It is divided into 7 types from 1 to 5. The cognac one has a direct anterior grade flow into the durovenous sinus, and usually it is benign lesions with 0% of suffering from aggressive symptoms. For type 2A, there's a drainage into the sinus with a retrograde flow within the sinus. For cognac 2B with the orange arrow, there's a drainage into the sinus with a retrograde flow into the cortical veins. For 2B and A, there's a combination of 2A and 2B. So there is a drainage into the sinus of retrograde flow within the sinus and cortical veins. For cognac 2 type 3, there's a direct drainage into the cortical vein without venous ectasia. And type 4, a direct drainage into the cortical vein with ectasia more than 5 millimeters or 3 times larger than the diameter of the draining vein. And for the type 5, there's a direct drainage into the spinal perimedullary veins. And studies have reported that higher grade patients will suffer from, will have higher rates of suffering from aggressive symptoms like hemorrhage or non-hemorrhagic neurological deficits. So about the treatment option, after obtaining the capital angiogram, the findings of DSA will define the symptom, the lesion, if it is benign or aggressive, and the risk of bleeding if not treated. For benign lesions classified as Borden type 1 or cognac 1 and 2A, all we have to do is observation and maybe a follow-up examination. And while aggressive lesion, there are some treatment options like endovascular embolization, surgical resection, and stereotactic radial surgery. Among that, endovascular embolization is the minimally invasive technique, which is can be considered as the first-line treatment of dural And if endovascular embolization is not feasible or insufficient, surgery can be necessary, and it can be open surgery or microsurgery. But there are some difficult lesions that need the combination of endovascular embolization and surgical resection. During the endovascular embolization procedure, a catheter is passed through the groin up into the arteries in the brain that lead to the dAVF and inject liquid embolic agents, such as Onax, glue, or NBCA, into these arteries. And this injection shuts off the artery and reduces the flow of blood through the dAVF. And these liquid embolic agents really are the help change of patient's life in terms of dural fistula. This is the findings of the imaging of Onax embolization procedure. With the first 2 pictures are pre-op and the rest are post-op. We can see here is a catheter going through the ophthalmic artery, and then the superficial temporal arteries on the right, and then superior temporal arteries on the left. And this is a post-op imaging. We can see there's no dural fistula. Even though endovascular embolization works in most of the cases, but there is a small number of patients suffering from complications like permanent neurological complications or recurrence, which can be detected through angiographic follow-up. And this is my presentation about dural fistula. So now let's move to the practical part. I will send you the link of case on Radiopedia.
Yeah, any question for the diagnosis of dAVF?
Okay.
Any question from the top first?
Okay, Ngọc. I think that it's a good starting point for newbie. The first question I want to ask you is that how can we differentiate between the dAVF with the other vascular?
Hello,
what?
Can you speak more slowly?
More slowly? Okay, slowly.
Yeah.
Okay. Can you how can we differentiate between the dAVF and the other kind of vascular malformation like AVM, like DVA, for example? What is the specific feature? What?
You mentioned AVF, AVM, right?
AVM, then DVA.
DVA.
What is the specific? Okay, you don't know about DVA. Okay, AVM only. AVM only. How can we differentiate between AVF and AVM?
DVA, what is that? I don't know.
No.
Well,
just forget about that. Just how can we differentiate between dAVF and AVM?
Okay. Like I mentioned before, although both they are high flow vascular malformation, they still some different features between the two types. First of all, it is the age. AVM usually occurs in children, or the early stage of life, while the dural fistula is occurred in middle age and older adults. And the second is AVM is most of AVM lesions are congenital, and the dural fistula is acquired lesions, probably after the sinus thrombosis, head trauma, or surgery using some kinds of drugs, infection, etc. And the place, the location of the lesions. AVM can occurs within the brain tissues, and dAVF occurs in the dural matter, which is outside the brain. But the symptoms can be similar, like brain hemorrhage. But we can, I think we can differentiate these two conditions. This is based on etiology and symptoms and age, something like that.
I think regarding on imaging feature, the most important one that to remember is just in case of AVM, the nidus is
most important thing.
Is located in the brain parenchyma, and in case of dAVF, is located at the duro sinus. Yeah? So it is extra parenchymal, and like in the talk, like Ngọc had mentioned in her talk, sometimes it's really hard to detect the fistula even on CTA or even in MRA. That's the reason why, you know, in case of dAVF, the DSA is considered as a gold standard, not not like AVM. In case of AVM, it can be, easily detected on non-invasive examination. For example, on CTA, for example. But in case of dAVF, the fistula is located in the durovenous sinus. So sometimes you just see, the hemorrhage, the intraparenchymal hemorrhage, for example. You can see the dilated vein. You can see the dilated, feeding artery, for example. But you cannot see directly the fistula location. That's the reason why, if you don't, if you have a case of young patient with, with lobar hemorrhage, and there is no parenchymonitis, but you still see the dilated vessel, for example, vein or feeding artery. You should think of, the dAVF, and you can request for the DSA for the definitive diagnosis. Is this okay, Ngô?
Yeah. I think the most important point is the nidus. Yeah, in my opinion, is the nidus because
location, right?
Yeah, location, the nidus. dAVF is what?
Located in the parenchymal, and one is located in the durosinus.
Yeah, in the durosinus.
Yeah. And it's more difficult when you have to differentiate on between the dAVF and the AVM in the spinal cord. It's really hard, because you just see the dilated venous, the dilated vessel structure. You cannot see, you don't see clearly the nidus, or you cannot, whether it is parenchymal or extra parenchymal, particularly in the
spinal location.
Yeah. Okay, so take a look on the playlist, please. Page number 1.
Who is the volunteer?
Can you do you want to do the first case? 5 years old.
Okay.
I will give you the remote control. Okay.
No, the really need. I can open the playlist by myself, and I share the screen. It's much more easier.
Yeah. Okay. Please turn off your screen sharing.
Did I share my screen?
Yes.
Huh?
Yeah, I
Not
can
yet?
see. Yes, yes, yes. I can see your screen. Your screen.
Just wait the playlist. Why is it? Yeah, it is. Okay.
Okay. Four cases.
A progressive parietal occipital headache with intermediate blurring of vision. 45.
Okay, now take a look on the initial CT scan first. It's non-contrast initial CT scan. What do you see here, Hang?
There's concept of SSS, sagittal sinus,
Yes.
big concepts, and mostly nothing else. No.
Đây thôi, không về à? Ai đang làm cây đấy?
Em.
Can you come back to the clinical presentation?
Có thấy màn mình không?
Yep. And even your voice. Headache and loss of vision. Okay.
No. The location of headache. They give you a clue of the location.
Parietal occipital. Okay, I take a mask. Okay. There are a little bit of a hemorrhage, subarachnoid hemorrhage, very close to the SS, in the posterior, first posterior, and close to this SS.
I don't think it's hemorrhage. See it on sagittal view.
Okay, I'm going to say
sagittal view, sagittal.
No, it's just a vein. It's a vessel. Vessel dilated, which come take has to SS. Okay, it is a vessel dilated, and we need to require for scan injection at the venous space.
Okay. Now take a look on the CT scan, on the follow-up after 1 day.
Okay. And there is a hemorrhage still intraparenchymal.
Next to the abnormal, dilated structure.
Dilated venous dilated vessel. Okay, there's a intraparenchymal hemorrhage, and after contrast, we could confirm the dilated of the vessel in dural and even in the parenchymal. But it's called the parachemo. Because I cannot find the needle, so it must be in IVF. And there is an hemorrhage in the intraparenchymal. So I incline towards IVF only.
Okay, now take a look on the ESA.
Okay. This on DSA we could see the reverse flow to the SS, not yeah. Come back to the posterior part of SS. That tie. No, I forgot to tie over idea. Type 4.
Okay. So what do you think, Ngọc?
Yeah, the answer cognac type 4 is right.
Okay, I can stop sharing.
So in the first case, we see we have yeah, I'm gonna start. I'm gonna share my screen. So in first case, we have a 45 male patient hospitalized due to the gradually progressive parietal occipital headache and blurring of vision. On the initial CT scan, we based on the clinical symptoms, we can detect the the hyperdense structure at the arachnoid space of the left occipital area. Okay, and which suggestive of dilated venous of the venous structure. Yeah, and after one day, the patient have a small intraparenchymal hemorrhage, and on CT scan we can see the dilated dilated vein, and dilated vein, and there is no intraparenchymal nidus. There is no intraparenchymal nidus, just the dilated vein, and some some, I think that there is some dilated feeding artery. That's next to the parenchymal hemorrhage, and the dAVF is confirmed on the DSA with the a fistula between a feeding artery would come from the posterior circulation and a cortical vein, and you can, and on this slide you can see that the dilated the ectasia of the cortical vein, which show the type 4 of cognac cognac classification, cognac or cogna classification. which is high rate of hemorrhagic complication. Okay, now let's move on to the case number 2. Who want to try the next case? Aku, do you want to try the next case?
My internet connection is so poor. I'm
Okay.
in and out from the beginning to now.
Hải Hà. Hello Hải Hà. Okay. So Hải Hà and chẩn đoán hình ảnh các học 29 as the same, right? One person. That's good. Nam, do you want to try this the second case?
Yes, I can. You see my screen?
Yes.
This male patient with sudden onset dry hemiplasia while traveling. On MRI, is a coronal T2. You see the lesion in the left thalamus with the blood flow. And I suggest the dilation of inferior sinus vein. We see on the statistical play dilation of this is a vein ectasis. There's this vein ectasis. In this see the flow in the vein, the ectasis vein, and on CTA. Oh. I see the is the nitrous and Venus enhancement and this vein enhancement. On DSA, it confirms the thesis of the Venus and
Thank you. Now we can skip this DSA because none of us here have have experience on on the intervention.
yes.
No. So we don't have to to focus.
Maybe
Much,
I suggest this is
much on the DSA. Okay, now can you turn off the screen sharing?
so my diagnosis.
Can you turn off your screen sharing? Okay, so I'm gonna share my screen now, and I think that our target today is how to make diagnosis or how to make a suggestion of dAVF on MRI or on the CT scan, right? And in this case, we have an old patient, 71 years old patient, and on the non-contrast sequences, we can detect, we can see a small hemorrhage on the left thalamic, right? On the left thalamic, which is located on located next to a dilated vessel at the inferior aspect of the hemorrhage. We can see a dilated vessel which show the connection with the deep venous system, right? Which drain to the deep venous system, and based on the non-contrast imaging, I think that it's very hard to say whether it is the AVM or it is the dAVF. We just see with us have the suspicion of arteriovenous malformation, for example, and the vessel malformation, and moreover, in the top, on the top, we can, you know, we can see the abnormal dilated, you know, arterial branch from the bilateral ECA. Okay, you can see that. Normally on top we don't see the branch from the ECA, and in this case you can see that there are, you know, several, you know, dilated arterial branches from bilateral ECA. So it's raised a suspicion of dAVF, because you know that the dAVF can, you know, can be supplied by from the brand of ECA. That's the reason why when we do the the DSA, we have to do the 6X, including the bilateral ECA. Normally for the AVM, the AVM is supplied from the ICA, right? But the dAVF can be supplied from the branches of the ECA. And on the CTA, we see the dilated vein, which drain to the deep venous structure. There's no more, you know, clearly information. And on the DSA, we see the connection, the side of dAVF, right? That side of dAVF in the deep structure here, and the most and you can see that it is supplied by mostly by the ECA branches, right? You can see this is a occipital branch of the ECA, which is dilated and which supply to the dAVF. So in brief, I think that the imaging finding that which success of dAVF on conventional MRI, on CT or on MRI is that you see a dilated vein, and you don't see the nidus, intraparenchymal nidus, and you see the dilated, you know, branches from the ECA, right? So there is the suggestive finding of a dural of the dAVF rather than an AVM. And we can, I think that we should skip the case number 3, because in this case we already have the DS, and this is not, you know, the one we focus on this talk. And on the last case, let's see what we have. We have a 30-year-old male patient, progressive hyperplasia and paralysis of the lower extremity over last 3 weeks. And on the MRI, we see the, you know, the hyperintensity at the medullary cervical junction. The hyperintensity on this area, on the medullary cervical junction. Okay, in this area, and there is no successive sign. But on the post contrast, you can see the dilated, you know, vessel around the cervical cord, which suggestive of you know, of vessel malformation. The vessel malformation, it can be, you know, AVM or it can be a dAVF, but we don't see clearly the nidus, the intraparenchymal nidus. We just see the dilated, you know, vessel. And on the CT angiogram, Also, we see the dilated vessel. We don't see clearly the nidus, intraparenchymal nidus, and on the DSA, we see the side of the fistula, which fitting by, you know, the arterial branches from the ICA, right? I think that is a brand from the ICA, and the nidus is the fistula is here, and we see the adrenis vein is here, which, you know, highly suggestive DSI with the dAVF. Whew. It's really hard, right? It's really hard to I think that it's really hard to detect the vessel anatomy in case of dAVF, but in regarding the diagnosis, I think it's not difficult. It's not really difficult. If we think of dAVF, we find the imaging characteristic of the dAVF, and I think we're gonna have the right answer if you think of the dAVF on the MRI or the CT scan. Do you have any comment, Duy Ngọc or Hải Anh?
I think it is in the last case. For the last case, without the contrast. What we MRI.
Yeah.
I think when we have the conventional MRI, what will have us to think about the vascular malformation if we don't have the contrast, because we don't do contrast regularly.
Regularly, right? Okay. I think in this case, if you have an abnormality at, on this area, on the medullary cervical junction, normally we request for the injection, right? The injection. But now take a look on the axial flare. On this slide, we can see, you know, the abnormal dilation of the vessel structure at this area, right? You can see that. And I think it's maybe a suggestion for the vascular malformation, right? Do you think so, Swan?
Yes, I think so. Yes,
so
I want to recommend about the when we see the lesion here, this lesion does not have a restricted diffusion. Okay. And yes, and we should find out the vessel dilation around, and what will help us to recommend the injection, and we have to think about the vascular malformation when I see this case.
Okay, thank you. So the dilated vascular structure around the abnormal signal intensity is a suggestive finding of vascular malformation, and we should, you know, do the injection. Request for the MRA or the CTA. Thank you, Swan. And any other comment? Duy, Ngọc or Hải?
No, I don't have any comment or question.
Thank you for your listening, and see you tomorrow. Bye bye.
Okay, thank you for joining my staff today. Bye.
Bye bye.